opportunity to attend this conference. I'm going to just talk about our experience with this case we had in pericardial mesothelioma. Uh, go. Okay. So we had this patient, 70-year-old guy who was being evaluated for worsening shortness of breath, initially on exertion, then eventually when at rest. And he was seen in our pulmonary office. Other than dyspnea, there was no real cough. Our review of system, only positive things were easy fatigability and new onset leg swelling. His history was significant for polymyalgia rheumatica. For the last couple of years, he was maintained on prednisone 5 milligram daily. And other than that, he had stage 2 chronic kidney disease. Baseline creatinine was around 1.6. With that, and the social history, positive for smoking more than 40 pack years. And also, he is a business owner for last many years, and his work is to install fireplaces. So potential asbestos exposure there, no significant family history there. Initial evaluation, physical exam was just significant for some volume overload, but other than that, nothing really jumping out. Initial lab work was also not very impressive. Long story short, he went for a CAT scan of chest for further evaluation. And interestingly, we found this ream of pericardial effusion and was defined as rather complex looking effusion. We went ahead with echocardiogram. It's not the best screen, but this is long axis parasternal view, and this is RV, this is LV, and you can see like behind the LV, it's a ream of calcified pleura. So, and this was followed by a right heart catheterization, which again, not naming all the signs we found, but did show evidence of pericardial restriction. So we just thought this would be a simple case of pericardial fibrosis without any known etiology at that time, and we went ahead for elective pericardiectomy. During the surgery, as soon as they opened the pericardium, they rather saw very fibrinous stuff encasing the heart as well as the base of aorta. So that was rather surprising, and this is something that we typically see with pleural mesothelioma that encases the heart. His post-op course was rather complicated, cardiogenic shock, probably from myocardial stunning after this kind of surgery, and renal failure with his pre-existing kidney disease. It was like he spent almost 30 days in the hospital. First few days, he was supported by RV Impella device. This is was something unique about our case. Recently, FDA approved this device to support this kind of post-cardiotomy, cardiogenic shock. And I think if it wasn't about with this Impella, probably the patient wouldn't have made it. Anyway, long story short, he was discharged at 30 days, and now, but then he's still on dialysis with this renal failure. Initially, just looked like ATN, but we are still waiting for him to respond. He's about 2 months out from this surgery. He's still in, and he's going to fall off as an outpatient for potential chemotherapy that he's interested in. But it's going to be a little complicated. So I thought it would be worth reviewing his slides. So poorly differentiated pleomorphic cells with high-grade atypia, and immunohistochemical. This is calretinine staining, which was positive. On top of that, he was also positive. It was also positive for cytokeratin CK7, and it was negative for other melanocyte or breast or lung or thyroid markers. Thinking about the management of this patient, pericardial mesothelioma itself has been very a rare entity among constituting less than 5% of total mesothelioma cases, and no real reported randomized data comparing the survival or symptom control in patients treated with surgery versus radiation plus chemotherapy. If somebody is considering surgical intervention, what we have found in the case reports, the pericardiectomy might help cure local disease, or it may at least provide some palliation in the symptoms by relieving constriction. But then, like I said, again, quite a number of reports had discussed about this kind of post-cardiotomy shock. And sometimes these patients are not being considered for surgical treatment just because of the high morbidity associated with this kind of procedure. Uh, so again, less than 5% of all mesothelioma. The one thing that is little different about pericardial mesothelioma is it's seen in more younger population, and the association with asbestos exposure is not that clearly evident. Like one study, case report, not reported case series, looked at the disease between 1972 to 1992, while was a while back, but they looked at 29 patients, only 5 of them had a significant asbestos exposure. So the association is not as strong as we see in pleural mesothelioma. Median survival is about 10 months, and obviously diagnosis requires a histologic evaluation, although imaging study like MRI might be helpful to get an idea how invasive the tumor might be, but ultimately we need a tissue diagnosis. And talking about this, systemic chemotherapy, a combination of platinum or pemetrexed with or a combination of doxorubicin, vincristine, cytoplasma has been found to be effective. Again, some case reports. And like I said before, no large-scale clinical randomized trial of chemotherapy or radiation therapy has been performed, or at least not that I came across. So it goes case by case as far as the management is concerned. And just to leave it on a positive note, there's this online website outlining the different ongoing trials in the realm of mesothelioma, mostly in the pleural mesothelioma. And some of which we heard about in the last couple of days, but mainly looking at measles virus, and trial of intraoperative photodynamic therapy, and mesothelioma cancer vaccines, just to name a few of them. But a lot more information will come out over the next few years once we have more data, more evidence supporting this. Thank you.
John.
You know, when the patient went to surgery and it was that constrictive, is there anything preventative, you know, that to be done? Obviously, the patient went into shock, but is there anything that could have been done? Because you said it can happen and can be anticipated.
Right.
That could have, you know, kind of prevented the cardiogenic shock. I mean, can you do something prophylactic in that setting?
Nothing that I'm aware of, but speaking to cardiology and CT surgery, they said like even with simple pericardiectomy, there is always a risk of this kind of cardiogenic shock. They call it myocardial stunning, at least over a few days. And this patient, rather the tumor, visually they could say like the tumor was infiltrating his myocardium, and it was really hard to strip. One can imagine like their experience with pleural mesothelioma, this kind of resections could be more aggressive. And like I said, hadn't been that Impella device, which recently came out, probably the patient couldn't have made just with the help of pressors, probably he couldn't make it. So,
great, thank you.
Thank you.